My name is Dr. Sara Ghorashian, and I am an honorary senior clinical lecturer at the UCL Institute of Child Health, and I'm also a consultant haematologist at Great Ormond Street Hospital. And so I was asked about the challenges for CAR T-cell therapies in Europe during the COVID-19 pandemic. And I guess the comments are that the delivery of CAR T-cell therapy is complex in a general setting, because we need to obtain T-cells from a patient, send them to a manufacturer, return them to the patient, and then deliver what is a fairly intensive treatment with associated short-term side effects. Particularly the longer-term side effects are probably easier to manage, and then setting that against what the alternatives are for the patient in that context. So the alternatives for another patient are often bone marrow transplantation, which is actually reasonably similar, only this time you obtain cells from a donor and try to deliver that in the context of an intensive therapy with both short and long-term side effects. So to some extent, delivery of CAR T-cell therapy may be more feasible, but it's a very centre-specific issue than in delivering allogeneic transplantation as an alternative. However, the logistics then of being able to obtain cells from a patient and being able to transport them to a manufacturer in the context potentially of lockdown and other restrictions means that there has been an impact on CAR T-cell therapy, no doubt, across Europe. We certainly had reports of centres who were in the middle of being accredited for CAR T-cell therapy, and that process couldn't go ahead. We had reports of clinical studies where the implementation was put on hold because of the COVID-19 pandemic. But where centres were already delivering CAR T-cell therapies, either in an academic or a commercial environment, it seemed to be that most centres, albeit with a delay, were able to proceed to continue to give those treatments. And we highlighted that in a presentation at EBMT this year. The delays were of variable length, most commonly a month or so, and in some cases indefinite. Patients were then potentially went on to have further therapies. There were a few patients who were documented, unfortunately, who relapsed or progressed in the interval waiting for their CAR T-cell therapies, and that was obviously an adverse outcome, which was unfortunate. But I think in general, where CAR T-cell centres were up and running with the restrictions on their ITU departments and other services, which may have been severely restricted, where possible, those patients were delayed for a minimum period. It generally seemed to be of the order of a few months, although some patients, as I mentioned, did have longer delays, which resulted in unfortunate outcomes for them. But in general, it was more feasible potentially to deliver CAR T-cell therapy than bone marrow transplantation in this context, and therefore most centres continued with some activity through this time. I think the major challenges going forward from here are the fact that different countries will have different peaks of the pandemic at different times. The vaccination rates are obviously different. There are now more patients who've received CAR T-cell therapy who may go on to have COVID infections and then will need to be managed in that context. And so really, I think we have to consider that depending on the local restrictions and the restrictions that impact on the manufacturer, it may or may not be possible to deliver CAR T-cell therapy with or without a delay. And that from here, really, the chances of the peaks being coordinated across Europe are less likely, as individual countries take individual measures to control the pandemic, and that has an impact on their local incidence. And then there's the fact of what is the impact of the infection, the vaccination on our patient cohorts, and what complications they may have. And this is very different depending on the disease setting, lymphoma, acute lymphoblastic leukemia, and the age context, pediatric versus adult. So I think we really have to learn to live with COVID, to plan our implementation and our logistics around that. But to some extent, CAR T-cell therapy provides a bit of an advantage in that it's generally a short-lived intensity of treatment, following which there are relatively restricted long-term complications, and that contrasts against bone marrow transplantation, where you have to manage the acute intensity of the situation as well as the long-term side effects. And obviously the impact of COVID in an allogeneic transplantation setting is more significant.